So this diagram represents what a continuous glucose monitor, or CGM, is, okay? And as we mentioned in the past, we would only get maybe 3, 4, if we were really lucky, 6 or 8 readings in a day, okay? Continuous glucose monitors can give readings every 1 to 5 minutes, depending on the system, okay? And how does this work? So what we're measuring with CGM is interstitial fluid, and you can see how we're measuring this via this little catheter that's inserted just underneath the skin and resides in the interstitial fluid. This is connected to a sensor, which then is able to send glucose readings to a display device or a receiver, depending on if patients are using a system-specific device or, as most patients do, a phone app that displays their sugar readings as they're changing throughout the day on their cellular device. And this can allow patients to have alarms set for if they're dropping or if they're already hypoglycemic, hyperglycemic, and it allows them to really see what's happening when they are eating, when they're exercising. And we know in many studies, CGM alone helps patients control their blood sugars better. And certainly for patients who are on insulin therapy, this has been an absolute revelation and has changed the way that we are able to manage diabetes for patients and adjust their therapy. And to highlight what I said on the last slide even more, okay, I want to spend some time on this slide because this really illustrates why CGM is so useful. So each of these panels, left, middle, and right, represents a different patient, okay? Now, for many years, all we had to help patients manage their diabetes is an A1C and then a few blood sugar readings every day, right? And remember, A1C is an average of blood sugar readings over the last 90 days. On the far left, each of these red dots represents a blood sugar reading, and you can see how across the board in each patient, all of the blood sugar readings are in normal range. However, you can see how much of a difference there is in the patient on the left, where this line, which represents all of the CGM readings that a patient may get throughout the day, is very different and much more stable compared to this patient in the middle, where you start to see more hyperglycemia, where they're above 180, which is this top line, or starting to see a few readings that are less than 70 or hypoglycemia, versus this patient on the far right, where you start to see a whole heck of a lot more variability with highs and lows. And yet, when you take the average of all of their readings, they still have an A1C of 7. But you can obviously see that there's a huge difference in terms of how patients are going to see their sugars every day, how they're going to feel throughout the day, and when they're eating their meals or exercising or what have you, how well they're sleeping at night. CGM just gives us so much more information to be able to really target our insulin therapy and other diabetes therapies as well. And it gives us a window into what's really going on a day-to-day basis for patients and helping them make lifestyle changes as well as changing our therapies. So it really gives us so much more information to be able to make intelligent and targeted therapeutic changes. What does this look like in practice? So I've given you 2 examples of what a printout for a patient would look like when they're using one of these devices, okay? And it really highlights it out nicely. I'm not going to spend a ton of time on this, but you can see it's telling you how often they're spending time between 70 and 180. It'll give you graphical representation of where patient sugars are higher, where they're lower, are they in range most of the time, are they out of range overnight, and you can really hone in on, okay, I need to change this dose or that dose and adjust my therapy in that manner. And just one other depiction of CGM and the tracings that you can see for patients. So these are individual days where you can see where their blood sugar, where their CGM readings were going for the day, right? So they're a little bit higher overnight here. Then they've started giving insulin in the morning, they came down, they had lunch, they went higher. So you can really start to dissect out where a patient's struggling with their blood sugars. Is it breakfast, lunch, dinner? Is it overnight? And where do we need to make some changes? So just a wealth of information that allows us to really help patients get their glucose levels to target. Okay, so that's monitoring blood sugar readings, but how do we get blood sugar readings to goal, right? So obviously for patients with type 1 diabetes, we do this via insulin, okay? And these are all subcutaneous injections. And we use two different types of insulin when they're doing multiple daily injections. We use basal, or the background insulin, which is typically a version of glargine. There are some other ones, including degludec, that we can use to provide a low background insulin amount throughout the day to maintain fasting glucose levels. And then we need insulins that act a little bit faster, that patients can give shortly before their meals to be able to allow that glucose to be absorbed intracellularly and out of the bloodstream to bring blood sugar readings back down to normal after a meal. And this is given through bolus insulin, and there's multiple options here as well, and we'll talk about that, as well as correction insulin to bring down higher readings because we either didn't get the dose right or they forgot to give their insulin or what have you. Okay, so we're going to talk more about that in the coming slides. So how do we dose insulin, right? Everything for insulin dosing goes back to the total daily dose, okay? And I'm going to highlight that, I'm going to abbreviate that as TDD, okay, total daily dose. So for patients with type 1 diabetes, they tend to be a little more insulin sensitive compared to our patients with type 2 diabetes, where they're more insulin resistant. And a safe starting dose for most patients with type 1 diabetes for their total daily dose is around 0.3 to 0.4 units per kilo, okay? So you can take their weight, you multiply it by 0.3 or 0.4 and get their total daily dose. If you take half of that dose, that's your basal insulin dose. So that's your glargine dose, right? And remember, and this is key, patients with type 1 diabetes have to have a basal insulin on board always, okay? We see this all the time where even for patients who are in the hospital, their basal insulin may get held and they go into DKA after they're already admitted to the hospital, okay? So it's not just patients not taking their insulin out of the hospital and then coming in. It a lot of times is us doing it to them, okay? So please, please, please don't forget this. Anyone with type 1 diabetes must always have basal insulin, regardless of whether they're NPO for a surgery the next day or whatever is going on. They have to have some amount of background insulin to maintain their sugar levels and prevent ketosis, where they go on to develop DKA, okay? For dosing their mealtime insulin, so many patients with type 1 diabetes will use a carb ratio, and you can calculate this by using the 500 rule, and it's 500 divided by the total daily dose, okay? So this will give you a ratio of, say, 1 unit of insulin covers 10 grams of carbs, okay? So then patients will count their carbs, and if they have 100 grams of carbs, and their carb ratio is 1 to 10, you divide that by 10 and they give 10 units of insulin for that, okay? So that's how you come up with that. Now, many patients will do fixed dosing, and many times we do that in the hospital as well. And there's ways to sort of manipulate their carb ratio based on how many grams of carbs they're having roughly for each meal to come up with a fixed dose in those situations. And then finally, the 1700 to 1800 rule helps us figure out what their correction factor is. And this is telling us 1 unit of insulin drops a patient's blood sugar by how many milligrams per deciliter, right? So you take 1700, 1800 divided by the total daily dose, and that's your correction factor. So it's saying 1 unit for, say, we are in the hospital and we're using 1 for 50. So 1 unit of insulin would drop their blood sugar 50 points, okay? So that's what the correction factor is. What are our options nowadays for insulin therapy? Okay, so we have ultra rapid and rapid acting insulins that we use for meals, right? Because we know that the blood sugar is going to rapidly rise after a meal, and we need a way to be able to get that glucose level out of the bloodstream and intracellularly for cells to be able to continue to function normally. And our ultra rapid acting insulins, rapid acting analogs, the most common ones you're going to see are Novolog or Humalog. There are certainly some ultra rapid acting that just have a quicker onset of action, like Fiasp, where maybe within 10 minutes, 15 minutes, you start to see the ultra rapid acting analogs start to work. So you can imagine that that would help patients who maybe dose their insulin a little bit late or right at the start of their meal, but continue to have rising levels afterwards, despite the dose being correct. But the majority of patients are on, Aspart, Lispro, glulisine, which is, Humalog, Novolog, and Lumjev. These take, about 20 to 30 minutes before they really start working. And for both of these, their peak effect is about an hour or two. but can last for up to, maybe 4 or 5 hours at most. These are predominantly the insulins that we're using for our patients with type 1 diabetes to manage their mealtime dosing. Some of the other insulins like regular or NPH, although we used to use those because it's all we had, they take quite a bit longer, up to an hour or longer before they start working. And so you can see how that's not really ideal for patients with type 1 who are so dependent on insulin dosing to maintain their blood sugar levels. Certainly, we do still see people with type 1 diabetes on these or even in mixed versions, which we'll talk more about in the type 2 diabetes lecture. Not ideal, but sometimes it's all we have. So it can be done, it's just not ideal. And then certainly the long-acting or ultra-long-acting, so the glargine or degludec, Tresiba, or more concentrated versions of glargine, where these are functioning and present for about 24 plus hours, right? So glargine lasts about 24. Tresiba, which is ultra-long-acting, can have half-life of multiple days. So just be aware that these are out there. You dose them pretty much the same. You have to be a little bit careful when you're converting and adjusting the dose for some of these longer acting insulins. So be aware that it's not necessarily a 1-to-1 conversion, but usually they're pretty close in their doses. Where do patients give their injections? So this is, I think, an underappreciated entity. So when patients give their injections in the abdomen, that's actually the fastest location for absorption. It can start to be working in about 15 minutes or so. The posterior lateral arm is another place that's actually fairly rapidly absorbed. When patients move to their thighs or their buttocks or lower back, it's actually quite a bit slower. And so I will tell patients, if you're going to do your thighs or your buttocks, maybe use your long-acting insulin, because we don't care about fast absorption there. That way they can save their abdomen and their posterior arms for the faster acting insulins for their mealtime dosing so that they can get it on board more quickly. Insulin pumps. So lots of patients with type 1 diabetes, and actually now patients with type 2 diabetes, because a few of these systems are actually approved for use in type 2 diabetes now. Talking about insulin pump therapy is beyond the scope and time that we have for this lecture. I just want you to be aware of some things with these devices. Be aware that there are new systems coming to market all the time. The other thing I want you to be aware is if patients are on an insulin pump, they are no longer on a basal insulin. They are not taking Lantus. They are not taking Tresiba or Toujeo. And if their insulin pump fails, or if for whatever reason you're taking their insulin pump off in the hospital, as soon as you take that insulin pump off, they now have no more sort of functional insulin delivery, okay? And they'll start making ketones within an hour or two of that pump coming off as the last bit of insulin that had recently been given wears off. So if you're going to take someone's insulin pump off, you have to start them on basal insulin shortly thereafter. You cannot wait. I can tell you that this even happens here still today, where patients have their insulin pumps taken off for whatever reason, and the following morning, no one has given them any basal insulin, and we look at their labs and they're in DKA. So it's super, super important for you to be aware that as soon as the insulin pump comes off, or if you're going to take it off, you have to give them basal insulin. Be aware that there are going to be some new order sets coming out that we're going to use for insulin pumps, that if we're going to discontinue an insulin pump, basal insulin must be ordered. So just be aware of that. So I showed you a few of the systems that we are using currently, okay? But I want you to be aware of what these pumps can do, okay? So with all the newer versions of insulin pumps these days, they're all utilizing algorithms to deliver insulin and automatically adjust it, okay? So insulin pumps are wearable devices that deliver insulin subcutaneously. And when patients wear these, they don't have to give multiple daily injections. And again, they're not on basal insulin. It allows for flexible insulin delivery. You can adjust insulin delivery based on the time of day, activity, or carb intake. But the pump is automatically adjusting insulin delivery based on what the CGM is telling it, right? So based on the current readings and trends, if the CGM value is decreasing or they're hypoglycemic, insulin delivery is either going to be stopped or turned down. If the blood sugar is rising or they're hyperglycemic, then insulin delivery is going to go up to try and bring those sugar readings back down into the normal range, okay? Patients can still make, with most of these systems, decisions based on their carbs, their activity, and their daily life. Of course, the ideal system is where patients put the pump on and they don't have to do anything. It's getting closer or moving towards that, but we still do not have any pump that patients are able to put on and then not interact with anymore. They still have to interact with their pumps. So just be aware of that. Another important thing to recognize is lipohypertrophy, right? I've given you some examples here over on the right. And this is really thickened, rubbery subcutaneous tissue, and it's due to multiple or repetitive insulin injections at or near the same site. We don't really fully understand, but it likely has to do with inflammation and exposure of adipocytes to insulin. It's actually pretty common, especially for patients who've had diabetes for many years where they were using less pure insulins, even 25, 30 years ago, so not that long ago. Or they were using animal insulins. And why this is important is because if they're injecting into these areas, they may not be absorbing their full insulin dose. And if you continue their insulin dose from home in the hospital and the nurses appropriately don't inject in these areas, they may start getting hypoglycemia. So you need to be aware of this. And you can look for this obviously on your exam when you're admitting patients to the hospital or seeing them new in the clinic. Some other just injection technique or other issues. So patients will reuse needles. I've given you what a new needle looks like in panel A on the top and what a reused needle looks like, magnified of course, in panel B. Really, patients should never be reusing needles for injection purposes. Of course, people do it from both cost or supply or other things, but really we want to make sure that patients are not doing that. Patients will inject through clothing to avoid sort of public exposure, which is obviously not recommended. They may use the pens incorrectly and inject air, or they may inject the needle place the needle under the skin and then dial the pen number. They're actually not absorbing, or they're not administering any insulin in that circumstance. They may have leakage because they didn't put the needle in far enough. Certainly, I see this a lot where patients are prescribed much longer pen needles than they need. You really don't need much more than 4 or 5 millimeters. 6, 7, 8 millimeters for the vast majority of patients is overkill, and it's actually probably inhibiting their insulin absorption by doing that. And then, of course, obviously, patients giving the incorrect doses. When we talk about differences in insulin therapy in patients with type 1 and type 2, really the overarching message is most patients with type 1 diabetes require less insulin. And the really important thing is again, patients with type 1 diabetes always have to have basal insulin. You cannot hold their basal insulin or they will be at risk for DKA even with one missed dose. So you have to have them have some form of basal insulin on board every day. A quick word on non-insulin agent therapies in patients with type 1 diabetes. There's only one that's FDA approved, which is pramlintide or synthetic amylin. It helps with insulin resistance, particularly with meals. The problem is you have to give an injection alongside an insulin injection with each meal. And so for the amount of glucose lowering that you get with this agent, we tend not to use it all that often. Some patients swear by it, and that's fine. But I tend not to use it all that often. Any of these other therapies are off-label, so we use metformin a decent amount to help with insulin resistance for maybe patients with a little bit higher BMI or struggle with insulin resistance. GLP-1 agonists, we do use them a lot if we can get them approved. Again, it's off-label, and it's really just to help them with weight loss and insulin resistance, and actually it works quite well in patients who have some insulin resistance. And there's really no risk of DKA or other issues in patients with type 1 diabetes. The main issue is getting them approved. Other medications, sulfonylureas, DPP-4 inhibitors don't work. And then a special comment on SGLT2 inhibitors, do not use them in patients with type 1 diabetes, okay? Their risk of DKA with these agents goes up dramatically, regardless of how well controlled they are. So really, you should never have any of your patients with type 1 diabetes on a SGLT2 inhibitor. And if you see that, you should stop it. It happens a lot where, cardiology or nephrology will add it because of the benefits that we know about, which we'll talk more about in the type 2 lecture. But really, you have to get them off of these medications. It should be, if they're going to be on them, it needs to be followed by endocrine closely and nobody else. I want to take the last couple minutes here just to review very quickly complications associated with diabetes. The difference for patients with type 1 diabetes compared to many patients with type 2 diabetes, although unfortunately type 2 diabetes incidence is on the rise in the pediatric population, but really it's lifelong exposure to poor metabolic health, right? And we know all the risk factors. And that's the difference for patients with type 1 diabetes, is it's lifelong exposure. And because of this, their risk of cardiovascular disease is extremely high. We can't talk about type 1 diabetes without bringing up the Diabetes Control and Complications Trial, or DCCT, which was the landmark study that showed that more intensive glucose control, A1Cs of around 7, versus conventional therapy, which was an A1C of around 9, which is hard to believe, but it was. When they followed these patients out, clearly there's a survival benefit in terms of lowering the risk of microalbuminuria and other microvascular complications for patients with type 1 diabetes. So I'd encourage you to look at this study, because this has really sort of framed the entirety of our diabetes care even to today. And I mentioned, the high cardiovascular risk in patients with type 1 diabetes. This is a slide looking at it's a cohort study from Sweden, where they looked at all patients with type 1 diabetes and compared their cardiovascular risk to 5 controls, age and sex matched. And what you can see here is across the board, regardless of age, their risk is at least 2 to 3 times higher than controls. And so across the board, patients with type 1 diabetes are much higher risk for cardiovascular disease. And the other thing I want to highlight is it's not just glucose control, okay? So if you look at that same cohort study that we looked at on the last slide, and you see patients with an A1C that's at goal, less than 7%, they still have a 3-fold risk, a higher risk of cardiovascular event. So death from cardiovascular disease, either stroke or heart attack, okay? So it's not just patients that have poor control who are at high risk of cardiovascular disease. It's all patients with type 1 diabetes who are higher risk. Just really quickly, I want to just mention this, because this is sort of my soapbox, if you will. We need to be more aggressive with cholesterol lowering in patients with type 1 diabetes, okay? This slide is really a amalgamation of all of the different society recommendations for what to do with LDL targets for patients with type 1 diabetes. And again, remember, the ADA is recommending, statins and LDL lowering, starting at age 40, or those with risk factors. Well, by the time patients with type 1 diabetes get to 40, they may have had diabetes for 30 years already. So I've put on here sort of my way of thinking about how do I best set up my patients with type 1 diabetes for not having a heart attack or a stroke by the time they get to be 40 or 50. And you can kind of look at these. Basically, the takeaway is those with risk factors or high risk, we really should be targeting an LDL less than 70 earlier. For those who are younger, haven't had diabetes quite as long, don't have any other complications, maybe an LDL under 100 is more of a reasonable target. So just be aware of these. I've put the guidelines to kind of take a look at yourself, but I will tell you it's very confusing when you look at the different societies. And so this is where I've kind of settled my practice on for patients with type 1 diabetes. When screening for complications in patients with type 1 diabetes, remember that their diagnosis, usually they haven't had diabetes for a long time, right? So you don't need to screen them right away. You can screen them within 5 years of diagnosis when you're talking about screening for diabetic retinopathy with a retinal imaging or dilated eye exam, screening for peripheral neuropathy, nephropathy, so urine microalbumin or albumin to creatinine ratio. And then, in terms of when to screen for some of these other things, obviously a lot of these things aren't going to develop until after they've had diabetes for many years. And use your clinical judgment when you're screening for erectile dysfunction, gastroparesis, osteoporosis, etc. When screening for other autoimmune diseases that are common with type 1 diabetes, I've listed the most common ones here in terms of autoimmune thyroid disease, both hypothyroidism and Graves', celiac disease, as well as adrenal insufficiency and some other conditions. Many of these we recommend screening on a regular basis, particularly the most common ones, thyroid and celiac disease. For some of these other ones, you kind of have to use your clinical judgment and be suspicious for other autoimmune diseases to screen those patients based on symptoms. To summarize, type 1 diabetes we know is a chronic autoimmune condition that ends in insulin deficiency, and this requires lifelong insulin therapy as well as ongoing support and education. You may have the wrong diagnosis. So many people that get diagnosed with type 2 diabetes may actually have type 1 diabetes. So I'm just asking you to be skeptical. Okay, if they're not responding the way that you think they should, They may need insulin therapy sooner, and you may need to rethink your diagnosis. And of course, the mainstay of treatment of type 1 diabetes is insulin, and I will also say continuous glucose monitors, okay? Insulin pump versus shots, I don't necessarily force patients to go one way or the other. I think the insulin pumps offer a lot more flexibility and a higher quality of life, but many patients don't want to have to wear another device, and I'm not going to force them to do that. But really, all patients with type 1 diabetes should be on a continuous glucose monitor due to the intensive insulin therapy that's required to manage the disease. With that, I'll stop. Thank you very much for your attention. I've listed my email here, so if you have any questions, please feel free to reach out to me whenever. Thank you.